Today's lecture is about the anterior pituitary hormones and growth hormones in detail. As you know, in central nervous system you have cerebral hemisphere, midbrain, pons, medulla oblongata, spinal cord and cerebellum. Please know these structures of the central nervous system very thoroughly, because it will be very useful in our all lectures. So where exactly this pituitary gland is located in the central nervous system? So here you have the hypothalamus, and near hypothalamus on the posterior side you have the thalamus. So under the hypothalamus you have the pituitary gland. This hypothalamus is a specialized structure in central nervous system, and anterior to the hypothalamus you have optic chiasma structure. From this optic chiasma you have the nerve fibers going to the eyeballs. So this is the front side, that is your anterior side, and there are mammillary bodies under the hypothalamus, and the downward continuation of the hypothalamus is known as medial eminence, and there is a tubular part known as pituitary stalk, and here you have the pituitary gland, and this is the anterior pituitary. As the name describes, it is on the front side, and this is the posterior pituitary. So here you have the anterior pituitary, posterior pituitary, pituitary stalk, medial eminence, you have mammillary body, and you have the hypothalamus. So where is this posterior pituitary derived from? This posterior pituitary is an extension of, basically it is an extension of central nervous system, that is it is a continuation, downward continuation from the hypothalamus. So you know that the thalamus part and the hypothalamus are derived from diencephalon. We will discuss about this diencephalon, metacephalon and other cephalons in cerebellum lecture in detail. In exam, if they ask about the derivative of posterior pituitary, you answer it is derived from the diencephalon, or you can also say that it is a derivative or downward extension of neural tissue. As it is the downward extension of neural tissue, you can see only the neural cells in the posterior pituitary, and that's all you have to know in this page. And so how about this anterior pituitary? Anterior pituitary, it is derived from the Rathke's pouch. So where do you exactly see this Rathke's pouch? In the nasopharynx. From the nasopharynx there is an upward continuation or upward evagination of the lining of the nasopharynx, and it forms a pouch. This pouch goes upwards and forms the anterior pituitary gland, and this pouch is known as Rathke's pouch. In nasopharynx you have epithelial cells, so you may see epithelial cells in the anterior pituitary. In posterior pituitary you see neural tissues such as modified astrocytes, that is pituocytes. So anterior pituitary is an upward evagination of nasopharynx, or it is derived from Rathke's pouch, Posterior pituitary is a downward extension of central nervous system, or you can say it is a derivative of diencephalon or derived from neural tissue. This neurohypophysis, we can also say this connection between hypothalamus and posterior pituitary, we can say it's a neurohypophysis. So what is the relationship between hypothalamus and pituitary gland? The posterior pituitary has a neuronal connection with the hypothalamus, since it is derived from the neural tissue from the central nervous system. This anterior pituitary has a vascular connection. We will see about this vascular connection in the coming lecture. So this pituitary gland, they sit in a sac-like structure known as sella turcica. So where do you exactly see this sella turcica structure? This is your head from the top view, and you have the nose anterior side, and you have the ears, and these are your cranial cavities, and here you have the sella turcica sac-like structure, and inside you have the anterior pituitary on the anterior side and posterior pituitary on the posterior side. So now we will see the relationship between the hypothalamus and the posterior pituitary gland. In hypothalamus you have nucleus, two nucleus such as supraoptic nucleus and paraventricular nucleus. So from this nucleus there are neurons, they have their cell bodies, axons and nerve terminal in the posterior pituitary. So basically there are storage vesicles in the cell body of the neuron, and they have the secretory granules in the nerve terminals. These nerve terminals we can also say as bulbous endings in as stated in other books. So in pituitary gland you can see the neural cells. I have mentioned that before, pitucytes, that is modified astrocytes. So I also have mentioned this neurohypophysis here. Neurohypophysis means the connection between the neural and the pituitary. So here you can see it is hypothalamic hypophysial neuronal connection. Hypothalamic hypophysial neuronal connection. So this nucleus, they have the cell bodies, that is the cell bodies of neurons. This is the axon. Inside the cell body you have the respective nucleus of the neuron, and here you have the neuron terminal or bulbous endings of the neurons. This supraoptic nucleus, they secrete, or you can say they synthesis Adh hormone, that is antidiuretic hormone. This Adh hormone is also known as vasopressin. So Adh is secreted or synthesized in supraoptic nucleus, and it comes down through the axons and it stays in the bulbous endings or nerve terminal of the neuron, and from here the Adh hormone is released into the circulation. This is the capillary which connects the circulation. So the Adh hormone is synthesized or secreted in the supraoptic nucleus, and it is released from the bulbous ending. So you can say in hypothalamus the ADH hormone is secreted or synthesized, and in posterior pituitary gland the ADH hormone is released into the circulation. This paraventricular nucleus synthesizes another hormone known as oxytocin. So same like supraoptic nucleus, oxytocin is secreted or synthesized in hypothalamus, and it is released from the pituitary gland into the circulation. So supraoptic nucleus also have oxytocin, but the percentage is 90% ADH and 10% oxytocin. Same goes for paraventricular nucleus. It synthesizes 90% oxytocin and 10% ADH. So these are simple concepts you should understand. And so this ADH hormone is a peptide hormone. So what do you mean by a peptide hormone? Peptide hormone have proteinaceous structure. So a protein is made up of amino acids. So proteinaceous structure basically means it is chain of amino acids. So how a protein is synthesized? In cell bodies, in the cell bodies you have DNA, and this DNA is transcripted into messenger RNA, and in this process you have the synthesis of protein. We will also see this in the coming lecture. So we know the hormones are secreted and synthesized in hypothalamus, and it is released from the posterior pituitary gland. How the release happens? It is through the action potential. Whenever the supraoptic nucleus or paraventricular nucleus is stimulated, there is an action potential from the nucleus goes down through the axon of the neuron, and it causes or it leads to calcium influx, and there will be exocytosis, and there will be the release of neuropeptides, that is the peptide hormones such as ADH, oxytocin into the circulation. So you will know about this action potential. This is a general concept about action potential. We will see about this in the action potential topic. And now we will see the function of ADH, that is antidiuretic hormone, and oxytocin. So what is the function of antidiuretic hormone? This ADH, it acts on the kidney. The function is antidiuresis. The name itself is self-explanatory. Antidiuretic hormone, antidiuresis. That means it will reabsorb the water, it save the water, and also it act on the vascular system. So what is the function of ADH and vascular system? That is, it is a vasoconstrictor. Vasoconstrictor means if this is a vessel, it will constrict the vessel. So ADH has two functions. One function, it acts on the nephron, and another function, it acts on the vascular system. The function of ADH and nephron is antidiuresis, and on vascular system is vasoconstrictor. So now the function of oxytocin. Please do not confuse the function of oxytocin with the function of prolactin hormone. So what is the difference between these two hormone functions is, prolactin, it synthesizes or it produces the milk. Oxytocin, it let out the milk from the breast nipple. So the function of oxytocin is only milk let out, not production. The function of prolactin is only milk production and not let out. So basically both of them depends on one another, and oxytocin has two functions. One is milk let out and another one is uterine contraction. Uterine contractions during delivery time, that is myometrial contraction. This oxytocin helps in the contraction of your uterine muscles during delivery. So now we will see the relationship between the hypothalamus and the anterior pituitary. In hypothalamus and posterior pituitary you have the ADH and oxytocin. So in anterior pituitary, I have mentioned earlier and also here, the hypothalamus posterior pituitary is a neuronal connection and the hypothalamus anterior pituitary is a vascular connection. So why do I say this? Because in near your hypothalamus you have two arteries, superior hypothalamic artery and inferior hypothalamic artery, and these arteries they enter the hypothalamus and they form fenestrated capillary network. That means artery, it will be converted into capillaries, and these capillaries when they go down the medial eminence pituitary stalk, they form as veins and it will lead to another capillary network and it continue with the circulation. So this connection, this vascular connection, it is known as hypophysial portal system. So hypophysial portal system. In posterior pituitary we have seen hypothalamic hypophysial neuronal connection. In anterior pituitary you have hypothalamic hypophysial vascular connection. Vascular connection also known as, you can say as, portal system or portal connection. So this change in the artery to capillary network, then to vein, then again to capillary network, and thus going into the circulation. And in hypothalamus you also have neurons. So these neurons also produces hormones. They go through the portal system down the anterior pituitary. In anterior pituitary also you have cells, but they are not neural cells, because anterior pituitary is derived from the Rathke's pouch, that is from the nasopharynx. So we will see in detail about the anterior pituitary gland. In hypothalamus you have preoptic nucleus, and ventromedial nucleus, paraventricular nucleus, arcuate nucleus. And this preoptic nucleus, it secretes gonadotrophin releasing hormone, and this ventromedial nucleus, it secretes growth hormone releasing hormone, and also it secretes somatostatin. So what is this somatostatin? Somatostatin, in other words you can say growth hormone, inhibiting hormone. So this ventromedial nucleus releases two hormones. One hormone, it will release the growth hormone, and another hormone named somatostatin, it will inhibit the growth hormone. And paraventricular nucleus, it secretes thyrotropic releasing hormone and corticotrophic releasing hormone. Arcuate nucleus, it releases the prolactin inhibiting factor. So know that ventromedial nucleus, this one, you have growth hormone releasing hormone, growth hormone inhibiting hormone, and arcuate nucleus, you have only prolactin inhibiting factor, also known as prolactin inhibiting hormone. Basically this prolactin inhibiting factor is a dopamine. You may have heard this word dopamine. And so now these hormones are released from their respective nucleus, and they are passed through the portal system, that is the vascular connection from the hypothalamus to the anterior pituitary gland. In anterior pituitary gland, you have what kind of cells? You have epithelial cells. So in anterior pituitary gland, you have matured cells and also you have immature cells. So these immature cells, they do not secrete hormones, or you can say they are poor secretary of hormones because they are immature. And these matured cells, they are able to secrete hormones. So this growth hormone releasing hormone and somatostatin, that is growth hormone inhibiting hormone, they go to one type of cells, and the other thyrotropic releasing hormone and corticotropic releasing hormone, they go to their respective cells, and prolactin inhibiting factor also it goes to the respective cell in the anterior pituitary gland. So what is the function of ventromedial nucleus? Because why we are studying about this ventromedial nucleus? Because from this ventromedial nucleus you have the growth hormone released or inhibited. So what is the function of ventromedial nucleus? Ventromedial nucleus, it is very helpful in the sampling of glucose and sampling of glucose in the blood and also other nutrients in the blood. Whenever you have increased glucose or high glucose in the blood, you have the feeling of satisfaction, that is what you feel after eating a meal. Whenever there is low glucose in the body, you have this hunger feeling. It is because of the ventromedial nucleus. Now I have told that there are matured and immature cells in the anterior pituitary gland. So these matured cells in the anterior pituitary gland are known as chromophilic cells. These immature cells in the anterior pituitary gland are known as chromophobic cells. Chromophobic means, phobia means basically fear. That is, in rabies you can see the patients have hydrophobia, that is the fear of water. So they are poorly secreting hormones. So in the chromophilic cells, that is in the matured cells, you have two type of families, that is acidophilic cells and basophilic cells. These chromophilic cells and chromophobic cells, that is matured and immature cells in the anterior pituitary gland, are 50% in proportion. So in chromophilic cells you have two type of cells, acidophilic cells and basophilic cells, and acidophilic cells are greater in proportion, that is 30%, and basophilic cells are 20%. So acidophilic cells, they the hormone, that is growth hormone releasing hormone, and somatostatin, that is growth hormone inhibiting hormone, they act on the acidophilic cell, and this prolactin inhibiting factor, that is dopamine, they act on the acidophilic cell, and thyrotrophic releasing hormone, corticotrophic releasing hormone, they act on the basophilic cells, and gonadotrophin releasing hormone, they act on the basophilic cells. So growth hormone releasing hormone, it stimulates this acidophilic cell, and growth hormone is secreted. This somatostatin, also known as growth hormone inhibiting hormone, it inhibit this acidophilic cell such that the growth hormone is inhibited, or it is not secreted. Prolactin inhibiting factor, that is prolactin hormone, we have seen the prolactin, the function of prolactin, that is milk production. This prolactin inhibiting factor, it inhibits the synthesis of prolactin, or it will decrease the prolactin secretions. This thyrotrophic releasing hormone act on the basophilic cells, and it secretes the thyroid stimulating hormone, and gonadotrophin releasing hormone, it acts on the basophilic cell, and the name itself is a self-explanatory, gonadotrophic releasing hormone, gonadotrophin releasing hormone, that is concerned, related with the gonads, that is male and female gonads. It secretes follicle stimulating hormone and luteinizing hormone. Corticotropic releasing hormone, it acts in the basophilic cell, and it secretes and releases adrenocarticotrophic hormone. These hormones are released into the circulation. There are capillaries attached closely with the anterior pituitary gland, since it has a vascular connection with the hypothalamus. So this growth hormone, it act directly on the tissue cells, or it act indirectly on the tissue cells. How it is? It acts indirectly on the tissue cells. This growth hormone, they go to the liver and they form somatomedians, and these somatomedians, they then act on the cells. So growth hormone can act directly on the tissue cells, and they also can act indirectly on the tissue cells through somatomedians. Growth hormone is produced in a pulsatile fashion. So what is this pulsatile fashion? You know the pulse, right? You have the pulse. For every beat you have this much pulse. So for every pulse you have this release of growth hormone. We will discuss about this pulsatile fashion later in this lecture. And this prolactin, the function of prolactin is milk let out. No, it is not the function of prolactin. The function of prolactin is milk production. So prolactin is the function of prolactin is milk production under the influence of oxytocin, because prolactin, it produce milk or it synthesizes milk only under the influence or under the support of oxytocin. The milk is let out of the breast. This TSH, thyroid stimulating hormone, it acts on the thyroid gland and it produces T4 and T3, that is thyroxine and triiodothyronine. And the gonadal hormones such as follicle stimulating hormone and luteinizing hormone in male, their function is on the spermatogenesis and testosterone, and females it is related with ovulation, progesterone, estrogen. So this adrenocarticotrophic hormone, they act on the name is a self-explanatory, adrenocarticotrophic hormone, adrenocarticotrophic hormone, ACTH, that is adrenal gland. Where do you find this adrenal gland? In the kidneys. Adrenocarticotrophic hormone, it acts on the suprarenal gland, that is exactly zona fasciculata of the suprarenal gland, and it produces glucocorticoids. So growth hormone, it can act directly on the cell, indirectly through somatomedians. Thyroid stimulating hormone, it acts on the thyroid gland and it releases thyroxine and triiodothyronine, also known as T4 and T3. Prolactin, the function is milk production. This FSH and LH, that is follicle stimulating hormone and luteinizing hormone, and males it is concerned with spermatogenesis and testosterone. In females it is concerned with ovulation, progesterone and estrogen. And this adrenocarticotrophic hormone act on the kidney and releases glucocorticoids. In acidophilic cells and basophilic cells, those acidophilic cells which secrete growth hormone are known as somatotrophs, and those acidophilic cells which secrete prolactin are known as lactotrophs, and those basophilic cells which secrete thyroid stimulating hormone are known as thyrotrophs, and those basophilic cells which secrete gonadal hormones such as follicle stimulating hormone and luteinizing hormones are known as gonadotrophs, and those basophilic cells which secrete adrenocarticotrophic hormone are known as corticotrophs. So somatotroph cells secrete growth hormone, lactotrophs, prolactin, thyrotrophs, thyroid stimulating hormone, gonadotrophs, follicle stimulating hormone and luteinizing hormone. Corticotrophs secrete adrenocarticotrophic hormone. This growth hormone releasing hormone stimulates somatotrophs and releases growth hormone. This somatostatin, it inhibits the somatotroph so that there will be very less secretion of growth hormone or no secretion of growth hormone. This prolactin inhibiting factor, this inhibit the secretion of prolactin. Then the other hormones, they stimulate the respective cells to secrete and release the hormones. Please do not confuse somatomedians with the somatostatin. Somatostatin, also known as growth hormone inhibiting hormone. Somatomedians means this growth hormone, it can act directly on the cells and it can act indirectly through somatomedians. So these somatomedians are made up of growth hormone, but somatostatin, it inhibits the growth hormone. So if there are more somatostatin, then there will be very less growth hormone, but if there are more growth hormone, there will be more somatomedians, because somatomedians are made up of growth hormones. Without growth hormone, there will be no somatomedians. And know that this growth hormone and prolactin comes under one family, and this thyroid stimulating hormone, follicle stimulating hormone, luteinizing hormone come under another family. And so there are two families here. So during pregnancy you will have the placenta. So this placenta produces human placental lactogen and human chorionic gonadotrophin. So this human placental lactogen, it comes under this family, growth hormone and prolactin. So it will become a member of this family. This human chorionic gonadotropin, it comes under this thyroid stimulating hormone and gonadal hormone, and it will become a part of this family. So in this family you have the alpha structures are in common, but the beta structures are different. Because of this different beta structure, you can distinguish, or you can have the difference between the TSH, FSH, LH and human chorionic gonadotropin, that is HCG. So with the help of the different beta unit, you can differentiate these hormones in this family. So placenta produces human placental lactogen and human chorionic gonadotropin during pregnancy. Now what happens during a trauma? So whenever there is a trauma to the anterior pituitary gland, what happens is there will be decreased synthesis of hormones. That is, the anterior pituitary hormones will be very low. So you have the growth hormone, you have TSH, FSH, LH and ACTH. During a trauma, there will be deficiency of these hormones except prolactin, because lactotrophs, the acidophil cell, it secretes prolactin, but from anterior pituitary gland, that is from hypothalamus, you have the prolactin inhibiting factor. It inhibits the secretion of prolactin normally. So in a trauma, there will be deficiency of all the hormones, but there will be only increase in the prolactin hormone, because this prolactin inhibiting factor will be disturbed. So it will no longer be able to inhibit this lactotroph cell. So there will be more release of prolactin. So whenever there is a trauma to the anterior pituitary gland, there will be deficiency of all the hormones except prolactin, because prolactin is increased during a trauma. So during pregnancy, the anterior pituitary gland becomes enlarged. So whenever the gland is enlarged, the blood supply, it also the blood supply or the requirement of blood also increases. So whenever there is an increase in the size of the organ, the blood flow requirement or blood supply to that particular organ, it increases. During pregnancy, after delivery, if there is excessive blood loss known as hemorrhage, that is after delivery, it is called postpartum, and before delivery it is known as prepartum. So if there is excessive blood loss after delivery, in medical it means the term is postpartum hemorrhage. So if there is 15 to 20% blood loss from the body, what happens is the body will go into shock. What happens during a shock is whenever there is 15 to 20% of blood loss, there will be only small amount of blood passing through your vessels, so the blood will become slower. So when they become very slow, it forms a clot, that is thrombosis. If there is a thrombosis, what happens is the blood flow to the tissues is affected, so the tissue will become infarcted, that is the tissues will die if there is no blood supply. So if there is no blood supply to the anterior pituitary because of the postpartum hemorrhage, the synthesis, the release of hormones, it is also disturbed. So there will be deficiency of hormones. If there is deficiency of hormones, each deficiency of each hormone is related with a specific disease. We will not discuss that clinical picture here. That the whole picture is known as Sheehan syndrome. So whenever there is a postpartum hemorrhage, there will be deficiency of hormones, so that all hormones are decreased or deficient except prolactin. As we have discussed earlier, during a trauma, all the hormones of pituitary will become deficient except prolactin. Prolactin will increase. So what is the treatment of Sheehan syndrome? In Sheehan syndrome, there is deficiency of hormones, so you give the hormone such as for thyroid stimulating hormone, you give T4, such a way you give glucocorticoid, prednisolone, estrogen, progesterone for the Sheehan syndrome. Now we will discuss growth hormone in detail. So growth hormone, the family of growth hormone is prolactin, human placenta lactogen. This human placenta lactogen is from placenta during pregnancy. So these are one family. So growth hormone releasing hormone, it releases growth hormone, and somatostatin, it inhibits the release of growth hormone. So understand the concept. Whenever the somatostatin is released, there will be decreased growth hormone. Since somatostatin, the function of somatostatin is inhibiting the growth hormone, so during daytime the somatostatin is released in higher amount. So whenever there is increased somatostatin, there will be decreased growth hormone. This growth hormone releasing hormone is released increasingly in higher amount during night time. So whenever there is increase in the release of growth hormone releasing hormone, what happens is there will be increased growth hormone, because the function of growth hormone releasing hormone, the name itself is self-explanatory. It releases growth hormone. So during night time the GnRH is increased, so growth hormone is increased during night time. During daytime this somatostatin is increased, so during daytime the growth hormone is decreased because somatostatin is increased. So we also know that the growth hormone is produced from an acidophilic cell known as somatotroph. So this growth hormone acts directly on the tissue cells or indirectly through somatomedians. know the difference between somatomedians and somatostatins. And growth hormone is a peptide hormone, we have discussed earlier, and the growth hormone is produced in pulsatile fashion. We will discuss about this later in this lecture. Since peptide hormone, growth hormone is a peptide hormone, it cannot act directly on the cell, so it need an mediator, that is it need a receptor to act on the cell. This receptor is known as one pass transmembrane receptor. There are also 7 pass transmembrane receptor, but here in growth hormone we will see only this one pass transmembrane receptor. Same it goes to somatomedians from the liver, because this growth hormone go to liver and it forms somatomedians, and this somatomedians through the one pass transmembrane receptor it act on the tissue cell. Now we will see what happens inside this tissue cell. In the tissue cell, the growth hormone and somatomedians arrive at the cell where they meet the one pass transmembrane receptor and attach to the transmembrane receptor. Then what happens is this transmembrane, one pass transmembrane receptor, it will undergo dimerization and it will form JAK kinases. So the full form of JAK kinases is Janus kinases, so we call it as JAK. This JAK kinases in turn it will lead to the phosphorylation of the one pass transmembrane receptor and the phosphorylation of JAK kinase itself. Then what happens is this JAK kinases after the phosphorylation it will activate or it will act on other inactive transitional factors in the cytoplasm of the cell, that is STAT. The full form of STAT is signal transduction and activator of transcription. So what happens after the activation of STAT? This STAT in turn it will act on the nucleus. Inside the nucleus you have the DNA, and after this action what happens is there will be transcription of DNA into mRNA and then translation of mRNA into proteins. This is how protein is synthesized inside the cell. So if there are any disturbances in the growth hormone level or somatomedian level, or if there are any disturbances in the receptors, one pass transmembrane receptor, what happens is there will be changes in the genomic expression, that is there will be disturbances in the transcription and translation and in the protein synthesis. And this STAT it will not only act on the DNA of the nucleus, some STAT it will also go into cytoplasm of the cell, so there will be changes in the metabolism of the body too. So now I will summarize the steps in this process inside a tissue cell. So when a growth hormone and somatomedians arrive at the cell, it will attach to the one pass transmembrane receptor, and such a way the receptors are activated and there will be a dimerization, and there will be formation of Janus kinases. This Janus kinases in turn it will lead to phosphorylation of the receptor and JAK kinases itself, and after the phosphorylation this JAK kinases it will act on the inactive transitional factors in the cytoplasm of the cell known as STAT, and this signal transduction and activator transcription, some it will go to the DNA of the nucleus, some it will go to the cytoplasm of the cell, and in the DNA of the nucleus there will be transcription of the DNA into mRNA and then translation into mRNA and synthesis of proteins. So now we will see the half-life of somatomedians and growth hormone. Somatomedians, they strongly bind with the plasma proteins in the blood. That means in the circulation the somatomedians will strongly bind with the plasma proteins in the blood, so that they will be much longer than the growth hormone in the circulation. Growth hormone, they weakly bind with the plasma proteins in the blood, so they will be very few minutes in the circulation. So the half-life of somatomedian is 20 hours and growth hormone is 20 minutes. Now we will discuss about the clinical correlation. What happens when the growth hormone is normal or growth hormone is higher than normal, but there are some disturbances in the somatomedian level, that is somatomedian levels are decreased. That is, we have discussed this earlier, that growth hormone can act directly on the tissue cell, and also it can act indirectly by going to liver, then forming somatomedians and acting on the tissue cell. So if the growth hormone, when they act on the liver, there will be a one-pass transmembrane receptor. If there are any disturbances to this one-pass transmembrane receptor, or you can say if there are any mutation in the receptor for growth hormone, what happens is the somatomedians, the growth hormone cannot stimulate the formation of somatomedians. In such a way there will be decrease in the level of somatomedians. So this clinical picture you can see in African pygmies. African pygmies are short in height, yet the growth hormone synthesis and release are normal. Only there will be decrease in the somatomedians due to the mutation in the receptor for the growth hormone. I will show you the picture of the African pygmies. So these are African pygmies. They are shorter in height than the average height of a human being. Now we will see pituitary dwarfism. Now we will see dwarfism. There are two kinds of dwarfism: pituitary dwarfism and Levy-Loren dwarfism. We have discussed that if there are any mutation to this one-pass transmembrane receptor or any disturbances to this one-pass transmembrane receptor, this growth hormone cannot stimulate the somatomedians. So even though when your growth hormone is normal or above normal, what happens is you will have a decreased somatomedians if there are any disturbances in the one-pass transmembrane receptor. And this picture you can see it in African pygmies. In pituitary dwarfism, what happens is in the anterior pituitary gland there will be disturbances in the release of growth hormone. So the growth hormone levels are decreased. If the level of growth hormone is decreased, in turn what happens is the somatomedian levels also decrease, because growth hormone forms somatomedians. If the level of growth hormone is decreased, somatomedians also decrease. This picture you see it in pituitary dwarfism. So what about Levy-Loren dwarfism? In Levy-Loren dwarfism there will be mutation or disturbances to this one-pass transmembrane receptor, So this growth hormone cannot stimulate the somatomedians. Even though the growth hormone levels are normal or above normal, the somatomedians are decreased because of the problem with the 1-pass transmembrane receptor. This picture, it is similar to the African pygmies, but in Levi-Lorain dwarfism it is not related to African pygmies. So you have to understand the concept when it comes to pituitary dwarfism, African pygmies and Levi-Lorain dwarfism. Levi-Lorain dwarfism, the levels of African pygmies the same or similar, yet it is not related to African pygmies. The maximum level of growth hormone is during the pubertal time. So the testes in male, ovaries in female, and adrenal glands, they synthesize androgens, and the increased amount of androgens they lead to the spurts of growth hormone. You may have heard this word growth spurt in the stages of puberty, also known as Turner staging. These are the stages of puberty in male and females. So where do you see these adrenal glands? These adrenal glands are situated or located above the kidney. So the androgens in males are more active than the androgens in females, because these androgens are synthesized from the testes. So in order to compensate that, in females the adrenal glands, they secrete and androgens, and they compensate for the growth spurt in females. So in adrenal glands, specifically adrenal cortex or suprarenal cortex, inside suprarenal cortex in the area of zona reticularis, you have the synthesis of androgens. So then the maximum frequency of pulsation of growth hormone. So what is this pulsation of growth hormone? It means growth hormone is released in a pulsatile fashion. We have discussed this earlier, that growth hormone is released in a pulsatile fashion, and this maximum release of growth hormone is during pubertal adolescent. So now we will see the function of growth hormone. Growth hormone has two functions, catabolic action and another one is anabolic action. In the catabolic action, the growth hormone, it will break down the lipids, the process known as lipolysis. And in anabolic action, what it will do is it will increase the protein mass. So here, for example, you take this person, what growth hormone will do is, if there is increase in growth hormone, the growth hormone through the catabolic action, it will burn all the extra fat lipids through lipolysis, and it will increase the protein mass. Basically, in common words, we can say there is an increase in the muscles of this person. So this is what they call it as lean body mass, because muscles are made up of proteins, and proteins are made up of amino acids. For muscle growth, you need proteins. Whenever there is increase in growth hormone, the excess fats or lipids, they are burnt through lipolysis, and through anabolic action, the muscles are increased, that is the muscle protein mass is increased. So whenever there is increase in the growth hormone, we have discussed already that there will be increase in the protein mass, and there will be breakdown of lipids. So what happens, we will see here in this picture. Whenever there is increase in the growth hormone, there will be increase in the process of transcription, translation, which lead to increase in the protein synthesis. And also know that whenever there is increase in the growth hormone, there will be increase in the uptake of amino acids from the circulation to the muscle tissue cell. So the usage of proteins by the muscles is now decreased. Know that muscles need proteins for their growth. Proteins are made up of amino acids. Whenever there is increase in the uptake of amino acids by the muscle tissue cells, that means there will be a formation of proteins. And also know that there is already an increase in the protein synthesis through transcription translation process. So protein catabolism is now decreased. Means protein catabolism means the breakdown of proteins for the muscle usage is now decreased. We already know that the main fuel for human body is glucose and fatty acids. Growth hormone release fatty acids from the fat deposits. If this is a fat deposit, growth hormone will release fatty acids from the fat deposits. And also you know that growth hormone has a catabolic action which will break down the lipids through lipolysis. So here is adipocyte tissue cell, that is a lipid cell. Inside an adipocyte or lipid or fat, you see glycerol. In glycerol you have monoglyceride, diglyceride, triglyceride fatty acids. So whenever there is increase in growth hormone, or what happens is this growth hormone will activate an enzyme named hormone sensitive lipase, and this hormone sensitive lipase enzyme will act on the glycerol and it will separate the glycerol and the fatty acids, and these fatty acids will go into the circulation and this glycerol will remain inside the adipocyte. This is how the growth hormone is able to break down lipids through lipolysis. Fatty acids means the fat. Now the fat is separated from the adipocyte tissue cell and it go into the circulation. In liver, you know that the free fatty acids, these are the free fatty acids. These are not free fatty acids because they are attached with glycerol. These free fatty acids, when they go to the liver, what happens is it will be converted into acetyl coenzyme A and ketone bodies. And if you know the biochemistry very well, the acetyl coenzyme A and ketone bodies, they will lead to the formation of glucose. So these free fatty acids are used for the energy instead of the proteins. This is known as protein sparing effect. Since the liver can use free fatty acids as the fuel for the body, and it will spare or it will leave the protein as it is. So it is known as protein sparing effect. Also know one important point, that the glucose formed by the free fatty acids cannot be uptake by the adipocyte cell. So even though the free fatty acids can form glucose as energy or fuel for the body, the adipocyte tissue cell cannot able to use this as a fuel. This is because of the growth hormone.
So whenever there is a increase or too much growth hormone, there will be too much free fatty acids. So whenever there is free fatty acids, there will be too much formation of glucose. That means there will be more fuel for the body or more energy for the body, but that is of no use because they cannot be uptaken by the adipocyte tissue cell as a fuel. And also know that whenever there is free fatty acids deposited in the liver in excess amount, it can also lead to another clinical condition called as fatty liver. So whenever there is increased growth hormone, there is a chance of having a fatty liver. Whenever there is an excess increase in growth hormone, there is a decreased uptake of glucose by the adipocyte tissue cell. So now what happens is, where will this glucose go if it is formed here in the liver? It will go into the circulation. So what happens in the circulation? There will be increased glucose in the plasma circulation. So it will lead to hyperglycemia, that is increased glucose in the blood. This so whenever there is an increased plasma glucose in the circulation, what happens is they will stimulate the pancreas automatically, and this stimulation, it will release insulin. Whenever there is too much glucose in the circulation, it will stimulate pancreas, and that will lead to the increase in the release of insulin. But this insulin is a free fatty acid resist insulin. So what is this free fatty acids resist insulin? Usually what happens is, in diabetic patients, they will have insulin injection. It is because insulin will make the uptake of glucose by the muscle tissue cell. Here in this process, whenever there is increase in growth hormone, there will be increase in the free fatty acids in the liver, and it will lead to the hyperglycemia, and it will also lead to the increase in the insulin. Here this insulin is resistance to the free fatty acids, that is this insulin cannot make the glucose uptake by the muscle tissue cell. So this insulin is of no use here. But if you give insulin injection externally through injections, or if insulin is formed in other way other than growth hormone, what happens is the glucose uptake by the muscle tissue cell happens. So this whole picture shows a diabetogenic and acromegaly patient's problem. Now the growth hormone, the catabolic action is lipolysis. It will break down the lipids, and the anabolic action of growth hormone is protein, increasing the protein mass, that is by indirectly acting on the somatomedians, and also it has glucose sparing effect and protein sparing effect. Glucose sparing effect means the free fatty acids will be used for the fuel of the body, and the glucose is spared, and also the protein is also not used for the fuel. So glucose sparing effect and protein sparing effect. So here during increase level of growth hormone that is higher than normal, the fatty acids are the main fuel for the body. Now we will see about the growth hormone effect on bone growth. So bone grows elongation. In bone growth there will be elongation of skeleton and there will be thickness of the skeleton. For example, take a tibia bone. Here you have the epiphysis and diaphysis, and here you have the growth plate known as metaphyseal plate. From the liver, when growth hormone act indirectly through somatomedians, when these somatomedians act on this growth plate, some somatomedians are also produced locally under the influence of the growth hormones here, since it is a growth plate. So what happens inside is the growth plate will be more active, and it will increase the chondrocytes and chondroblast. Then it will increase the collagen and cartilaginous material, and it will lead to osteoid, that is newly formed bone, and it will lead to the mineralization and the formation of bone. This epiphysis and diaphysis, you have a growth plate in between, and this growth plate can increase in length. This bone can increase in length until this epiphysis and diaphysis close together, or we can say fuse together. So if epiphysis and diaphysis are separate, or we can say not fused, there will be elongation of the bone. If the epiphysis and diaphysis are fused together, then if there are more growth hormone, then what happens is the bone cannot grow in length, but what it can do is it can add to the thickness of the bone. That's what we will see now. If growth hormone is in normal concentration, it is significant. It is significant means it is enough for the elongation of the bone. And if the level of growth hormone is low or deficient, the growth plates unable to add to the length. So this will lead to dwarfism, that is shorter in height. If during puberty, before closure of epiphysis, that is still the epiphysis and diaphysis are separate, and during puberty if there is more growth hormone, that is higher than normal, what happens is it still can add length to the bone, since the epiphysis and diaphysis are not fused together. So it will lead to gigantism, that is these persons will have a height which is above than the average height. And if a person has a normal height and the epiphysis and diaphysis fused together, so now there is closure of epiphysis. Now the bone cannot add to its length. Now if there is increase in the growth hormone level, increase means above, higher than normal, now what happens is it will add thickness to the bone, and this will lead to acromegaly. So in gigantism, before closure of epiphysis, that is before the fusion of epiphysis and diaphysis, if the growth hormone level, usually
the closure of epiphysis, it will happen at the end of puberty. So before puberty or during puberty, we have seen already that the growth hormone is very active or produced in a pulsatile fashion during the pubertal time. So if a person has a high level of growth hormone during pubertal time or before puberty, before closure of epiphysis, it will lead to gigantism. And if a person has normal height and this closure of epiphysis and diaphysis, that is epiphysis and diaphysis are fused together. Now if the person has increase in growth hormone, it will lead to acromegaly condition. That is, it will lead to thickness of the bone, especially in the membranous bone. Membranous bones, example, your skull bone, the face bones, and part of your clavicle are your membranous bones in the body. Now we will see the regulation of growth hormone. So in regulation of growth hormone, we have already seen earlier in this lecture that somatostatin, they inhibit the growth hormone synthesis, and growth hormone releasing factor, they stimulate the growth hormone synthesis and release. So now there are growth hormone releasing factor is a stimulatory factor and somatostatin is an inhibitory factor. And I repeat again, please do not confuse between somatostatin and somatomedian. Somatomedian is in the liver. Growth hormone will form somatomedians. Somatostatin will inhibit the synthesis and release of growth hormone. So now in the anterior pituitary gland, you have the somatotroph cell, the acidophilic cell. So this stimulatory factor, growth hormone releasing factor, it cannot go directly, it cannot act directly on the somatotroph cell. It will act through a receptor known as serpentine receptor, and it will stimulate the GS, that is G stimulatory protein inside the somatotroph cell. And in such a way, this G stimulatory protein will increase the intracellular cyclic AMP, and there will be release of growth hormone into the circulation. This inhibitory factor, somatostatin, it will also act through serpentine receptor, and it will activate the G inhibitory protein. In such a way, this G inhibitory protein, it will decrease the intracellular cyclic AMP, and thus reducing or decreasing the growth hormone synthesis and release. So when growth hormone is released into the circulation, it will go to the liver and it will form somatomedians. These somatomedians go back to the circulation. If the growth hormone levels are higher than normal in the circulation, what happens is this growth hormone, it will act on the inhibitory factor, and it will activate the inhibitory factor, activate or stimulate this inhibitory factor. You know that the inhibitory factor, that is somatostatin, normal action is inhibiting the growth hormone synthesis and release by acting through G inhibitory protein. And also know that if the growth hormone levels are higher than normal in the circulation, you know that the somatomedian levels are also higher. So these somatomedians in the circulation, there are some classes of somatomedians such as somatomedian C, also known as insulin like growth factor 1. It will act on the serpentine receptor, and it will deactivate the serpentine receptor, or we can say it will deactivate or inhibit the G stimulatory protein through serpentine receptor. In such a way, the growth hormone synthesis and release is reduced dramatically. And also know that somatomedians can also act directly on the inhibitory factor, and it will activate or stimulate the somatostatin, that is the inhibitory factor. And you know that the somatostatin normal action is to inhibit the growth hormone synthesis and production by activating the G inhibitory protein through this serpentine receptor. This is the regulation of growth hormone. So I will summarize. The normal function of a stimulatory factor, that is growth hormone releasing factor, is activating the G stimulatory protein inside the somatotroph cell by acting through the serpentine receptor. The normal function of the inhibitory factor, that is somatostatin, is inhibiting the growth hormone synthesis and release by activating the G inhibitory protein through serpentine receptor. If the growth hormone is higher than normal in the circulation, this growth hormone will activate or stimulate this inhibitory factor, and you know the function of the somatostatin and what happens after that. If the growth hormone is higher than normal in circulation, you also know that there is increase in the level of somatomedians, and there are somatomedian C or insulin like growth factor 1 in circulation, and this will inhibit or deactivate the serpentine receptor so that the G stimulatory protein is not activated. And these somatomedians in circulation can also act directly on the inhibitory factor and stimulate or activate the inhibitory factor, and you know what happens when the inhibitory factor is activated. So this is the normal feedback system, and this is why there is increase in the growth hormone levels during night time and increase in the somatostatin levels during daytime. This is how the body maintains the regulation of the hormones. Now we will see about the pulsatile fashion of growth hormone production. Growth hormone is produced in pulsatile fashion. I have mentioned this earlier in this lecture many times. So a normal pulse appears every 2 hours. So whenever the pulse appears, the growth hormone is also released or produced. The pulse frequency and intensity during night time or during sleep is very high. That's why the growth hormone levels are higher during night time or when you sleep. The somatostatin levels are higher during daytime, so that your growth hormone levels are lower or decreased during daytime. And also know that during stress, exercise, trauma, and for stress management, if you consume alpha adrenergic agonist drugs, these will increase the growth hormone levels in your body. And know that whenever the growth hormone levels are higher than normal, your blood glucose levels are also normal, and your free fatty acids are also increased. So whenever there is very higher level of blood glucose in the circulation, what happens is your growth hormone is decreased. Whenever there is very higher level of free fatty acids, your growth hormone is decreased. So this is how the regulation happens. And during puberty, as we have discussed earlier in the lecture, the growth hormone is increase. With age, that is during puberty or before puberty, your growth hormone is very higher. When you age, that is from 15 to 20 to 30, 40, 50, when you age, when you are older, what happens is your growth hormone decreases drastically. And in obese patients or obese persons, the growth hormone levels are lower. And in hypoglycemia means there is no glucose in the body, in the circulation. What happens is, if there is no glucose in the circulation, your growth hormone level will increase. If the growth hormone levels are increased, what happens is automatically your blood glucose levels will increase. So whenever there is a hypoglycemia, your growth hormone levels are increased. And whenever there is low free fatty acids, your growth hormone levels are increased. Whenever there is increase in the growth hormone level, your free fatty acids are also increased. So if you have a somatostatin injections, what is the normal function of somatostatin? It is inhibition of growth hormone synthesis and release. If you have a disturbance in somatostatin factor and you have excess growth hormone level in your body, if you have somatostatin injection externally, your growth hormone levels will decrease. What if you take somatomedian injections? If you take somatomedian injections, what happens is the somatomedian levels in the circulation will be higher. We have already discussed that whenever there is increase in the level of somatomedian, what happens is either the somatomedian C or insulin like growth factor, it will inhibit or deactivate the serpentine receptor so that the G stimulatory protein is not activated and growth hormone levels are decreased, or the somatomedian will act directly on the inhibitory factor and it will stimulate the somatostatin. In either way, the growth hormone levels are decreased if and only if there is excess somatomedian level in the circulation. So what if you take growth hormone injections? As we have discussed earlier, if you take growth hormone injections, your growth hormone levels will be lower, because if the growth hormone levels are higher in the circulation, the growth hormone itself will act on somatostatin and it will stimulate the somatostatin and inhibit the synthesis and release of growth hormone. What if you take beta adrenergic agonist drugs? As I have mentioned earlier, this alpha adrenergic agonist drugs is taken during stress. During stress, your growth hormone is increase than normal level. So if you further take beta adrenergic agonist drugs, there will be very increase in the growth hormone levels in turn. As I have discussed earlier, if there is higher level, the growth hormone levels will decrease automatically through the regulation or feedback system. So please understand the concepts. Then arginine is an amino acid. It is also a strong stimulant of growth hormone. And know that during pregnancy your growth hormone levels are decreased or lower. It is because the fetus inside the mother need more amino acids, that is more proteins and more glucose. So what happens is during pregnancy the growth hormone levels will be increased to produce this enough amino acids and glucose for the fetus. So whenever there is an increase in the growth hormone level, the circulation, the growth hormone, the feedback system, it will automatically decrease the growth hormone levels. So during pregnancy, growth hormone levels are decreased. Always know the feedback system concept thoroughly so that you can answer the questions very easily. Now we will see some clinical correlation related with decreased growth hormone or low level of growth hormone. In pan-hypopituitarism in children, the anterior pituitary gland is destroyed or disturbed by a tumor or trauma or metastasis. Metastasis means the extension of tumor from other parts of the body, radiation or any other congenital diseases, and these children have pituitary dwarfism. And these pituitary dwarfism patients, they never pass puberty and they will also have hypothyroidism. As we have discussed earlier, that if there are any disturbances in the anterior pituitary gland, the release of hormones are decreased. If the release of hormones are decreased, then there will be consequences. So in why they never pass puberty, it is because of the decreased follicle stimulating hormone and luteinizing hormone. Why they have hypothyroidism? Because there is low level of thyroid stimulating hormone. In dwarfism, you have two kind of dwarfism, pituitary and Lorraine dwarfism. In pituitary dwarfism, as we have discussed earlier, there will be low level of growth hormone, and in such a way there will be low level of somatomedians. In Lorraine dwarfism, the growth hormone levels are normal, but what is abnormal is, or what is very low is, this somatomedian C or insulin like growth factor 1 is very low. In pan-hypopituitarism in adults, whenever there is a tumor such as craniopharyngioma, that is the tumor derived from Rathke's pouch. You know Rathke's pouch, the pouch from the nasopharynx, and chromosomes tumors. These tumors in turn, it will compress the optic chiasma. You know, in central nervous system you have hypothalamus and you have optic chiasma, and from this optic chiasma you have optic nerve fibers going to your eyeballs, and if there are any disturbances, it will affect your vision. So you will the patients have bitemporal hemianopia. If there are any tumors that compress against the blood vessels in the hypothalamus going to the anterior pituitary gland, what happens is the blood supply cannot happen to the anterior pituitary, and in turn there will be infarction. That is, if there is no blood supply, the tissue cells, they will die of no blood supply, and you see the Sheehan syndrome. We have discussed the Sheehan syndrome earlier in this lecture. And when there is a high growth hormone, what happens is you can see gigantism in children. This is the average height of a male human being. This is gigantism, and you may also have heard these giants in Bible. And this gigantism happens before the closure of epiphysis, that is before puberty or during puberty, if there is increase in the growth hormone levels. And what happens is the length, it will add to the length. So the body skeleton and soft tissue, they will increase in equal proportion. In acromegaly, what happens is these acromegalic patients, there will be increase in the growth hormone after the closure of epiphysis. So the bone cannot add to the length. Instead, what happens is it can add only to the thickness, because there is closure of epiphysis. So what happens is there will only increase in the soft tissue, and there will not be any increase in the length of the body skeleton. So you can see abnormal vertebral growth, such as you see in kyphosis, or you can see the growth in membranous bone, increase in thickness of the membranous bone such as your facial bones, jaw bones, etc. So that's it for the anterior pituitary hormones and growth hormone. In next lecture we will see about the posterior pituitary hormones.